so I'm a little short on time. I'll try and see how I can finish. So the first topic is post-cataract surgery refractive surprise. It's better to be safe and rather than sorry later. So these are the eyes where you can have refractive surprises. So please be extra careful when you're dealing with these kind of eyes and do all the necessary steps which have been elaborated by my previous speakers. If it does happen, then you need to figure out why it happened, and then you need to look at everything. Could it be because of a scar, or is it because of irregular cornea? Is there possibility of a capsular distension, IOL malposition? Was it a biometry error? So you need to go back and look at everything. If necessary, repeat the biometry and see where things went wrong. And then you have to think about how you want to deal with it, whether you want to change the lens or do a piggyback lens or do some sort of a cornea-based procedure like an ablative refractive surgery. And if there is some other cause like a capsular distension or the lens being malpositioned, then you have to address that surgically. So in the immediate post-operative period, it's important to recheck everything, including IOL calculation in pseudophakic mode, check the preoperative data, IOL par calculations, make sure that the right patient has the right lens. Sometimes you've done everything but you put the wrong lens in. And rule out a capsular block syndrome, which can cause a myopic surprise. So if it's a multifocal lens and patient comes, say, 2 to 4 weeks after surgery, it's a good idea to just change the lens. But if you're not keen to do that, you could put a piggyback as well. But if the patient is coming several months after surgery, then it's likely that the IOL would be adherent to the capsule to some extent. And in such cases, better not to damage the capsule and just go ahead and put a piggyback lens if that is feasible. Otherwise, you can do a corneal ablative refractive surgery like a LASIK or a surface ablation. If it is a monofocal lens, up to 4 weeks, IOL exchange, piggyback, and surface ablation or LASIK all are good options. And more than 4 weeks later, then again piggyback or a surface ablation or LASIK. But if you're doing a femtop flap, make sure that the hinge is at the wound site. Toric IOLs, if the IOL gets rotated, then one could rotate it back to the original axis. If you do not have the original calculation, then you can use these websites like astigmatismfix.com, or if you have a ray tracing aberrometer like the iTrace, that will help you to identify which is the correct axis in which the lens should be played. Excimer, either wavefront guided ablation, not a topography guided ablation, IOL exchange or a piggyback IOL could be used in extreme cases. So this is just the website of astigmatismfix.com. You just need to put in your data and it will then give you a calculation of what should be the new axis of your lens and how much you need to rotate. IOL exchange, this is a video I borrowed from my friend Harshul. So basically what you could do is you could put in bring the first lens out of the bag, put in the second lens in the bag before you explant the second, the original lens, which is like, it acts like a scaffold. And then you can go ahead and cut and remove the lens so that you don't accidentally damage the capsule and there is some protection of the other lens. So this is just one case I'll share with you. This was a patient that had an uneventful cataract surgery, and you can see lens is looking well in place and eyes quiet, but we had a refractive surprise of 2 diopters. And as you can see on the slit, there is a gap between the PC and the posterior surface of the IOL. So this is basically a capsular distension syndrome. The viscoelastic was not adequately removed, and same thing is confirmed on the OCT. You can see the gap there. So one can try to do a yak to the peripheral anterior capsule, or you could yak the posterior capsule, or you can go in and do a visco wash. So in this particular case, we did a yak to the peripheral anterior capsule. You can see that star shape mark over there. Same thing is visible on retroillumination. And postoperatively, immediately the patient's refractive surprise resolved. Of course, the prevention of this is to do a good OVD wash. So go behind the lens also and wash it out. This is another patient, 61-year-old female, underwent a multifocal IOL 6 months prior, and then after 6 months when she came, this was the kind of refraction I was dealing with. So very, very unhappy patient. Obviously, she wanted unaided near vision and distance 6, 6 and 6, and this is what we are giving her. So basic what happened in this case is there was a phimosis which has displaced the lens anteriorly, and there was a change in the effective lens position as well. Plus, I think there was some calculation error as well. So what we did in this case was we planned for a piggyback sulcoflex toric because there was also a cylinder. So this is made from Care Group. We also have from Reina similar lenses, and we just excised the entire phimosed anterior capsule and opened up the anterior capsule, and we subsequently then put the secondary piggyback lens in the sulcus, as you will just see. So you have to inflate the sulcus and then basically take this lens and inject it anterior to the anterior capsule. It's pretty good option which is now available to us because Care Group makes it, and you just need to tuck it in like any plate haptic lens. And this patient, you can see the two lenses on the slit, did very well and was unaided 6/6 N6 subsequently. So ideal candidate for a piggyback lens is primary IOL should be intact and the capsular bag should be intact, pupil, iris, everything should be healthy, and of course endothelium, there should be no glaucoma, etc. So this is the way to calculate for piggyback lenses. If it is a hyperopic error, spherical equivalent to 1.5, myopic error spherical equivalent to 1.2. And sulcoflex is the other one from Reina. So to conclude, refractive surprises are best prevented by good biometry practices and surgical safety practices, and can easily be treated by cornea and lens based approaches with good outcomes.